Me?
Yeah.
I work on a cardiac telly before.
Okay, so you see rhythms all the time. How about listening to heart murmurs, heart sounds?
Yes.
Yeah.
Yes, you feel comfortable with that?
Not comfortable with heart murmurs, but with cardiac in general.
Cardiac in general. How about heart sounds? Listen to a murmur, being able to describe the murmur.
Not quite.
Not quite.
Not quite, not quite. Okay, it's a trick, right? I mean,
Come in.
I wish.
okay, well, we'll try to go through this, I guess. Okay. So of course, so these are listed as the four main components of the exam, right? It's really taking the history, right? That goes back to that subjective part of it. Performing the physical exam, the cardiovascular exam. I guess we can include heart sounds and murmurs, right? They're really included, but they're kind of broken out from the physical exam component because they're kind of a special skill outside of that. So we kind of know from the beginning of a physical examination, the first place we always start with the physical examination is where?
Inspection.
Inspection, right? So we're going to look at the chest. So again, this is going to be challenging if you actually never have the patient take their gown off or their shirt off or something like this. So I would encourage you to actually sort of get in the habit of doing that. This because it's probably best practice. You see probably all types of things where we don't really do that, right? So looking at jugular veins, and where are the jugular veins generally? In the neck, right? Okay, so we should be looking for any distension. This is inspection still, so any obvious on this, right? So different, different types of signs suggesting that there's problems, whether it's in the liver or some pericardial disease as well. And we'll go in details with some of the stuff that's most relevant for you. But remember, that's what inspection serves. Inspection serves the purpose of guiding our process. And now, we did history last week, right? So our subjective informs our objective. And this is our objective indicators. So our objective informs what?
Measurable.
What we see.
Measurable.
Well, that's what they are, but what do they inform?
The assessment.
Assessment, the diagnosis, development, right? They should be supporting that, and therefore then diagnosis informs what?
Plan.
The plan, the evaluation of the diagnosis. So this is kind of how it all connects, and it turns out they're all important.
Okay.
So we're probably all pretty good with chest pain. We know that chest pain is that, that kind of classic that we always talk about with cardiovascular disease, and these are some characteristics of this. But remember, cardiovascular can appear, as obviously pain related, can have pulmonary type symptoms, shortness of breath, could be confused with neurological symptoms like dizziness or syncope, right? But syncope can be related to reflexes in your arteries as well too. Or just dysrhythmias, arrhythmias, problems with the conduction system of the heart, because oftentimes what we're doing here is we're going to look at the heart in the mechanical part of it, right? It is like an engine in that regards, right? In what way is it kind of like an engine? What's the electrical part of an engine?
The battery.
Well, the battery, if you have if you have a hybrid, there's obviously an obvious electrical component with batteries and the way things work, right? There are obviously lights and stuff like that. That's the electrical component of it, right? But it's the conduction system is, the battery usually generates a spark in the spark plug, which causes the fuel to ignite, combust, and creates manual physical movement and translation into that. So that's where the conduction system meets the mechanical component, and the same as the heart. What is the purpose of the conduction system? To initiate the physical movement, the contraction. So it's the same kind of concept on that, right? So. Again, if we have any questions at any time, just ask me. Okay, so with listening from, whether we're looking at the conduction system or the mechanical parts of it, it's kind of helpful to know the position of the heart, right? So in some of the terminologies on this, right? So which part is the base of the heart?
The top.
The top,
The top, right? You wouldn't think that's the base, right? Which part is the apex?
the bottom.
The bottom.
Well, that's, I guess, the part that kind of goes towards an A. So that one's a little easier, strange, right? And then the right ventricle is on the right side, and the left ventricle is on the left side.
No.
And there's how many chambers in the heart?
Four.
Four. But this is very basic, right? It seems that way. It's all very basic. But it's kind of really important when we look at murmurs of positions, determining if something's diastolic, systolic, you know, what it might be, the mitral valve, tricuspid, aortic, or pulmonic. So give you an idea of the flow through the heart.
Right
Let's start with the
ventricle.
vena cava. Let's start, blood comes up from
The vena cava.
The
Into
vena
the right
everywhere.
air, the
Yeah.
body.
Go to the right atrium.
The right atrium.
I got a lot of them. I guess you can't hear. Who want, you start.
Okay, blood comes from, like you said, from everywhere, inferior and superior vena cava, and
Into
to
where?
the right atrium.
Right atrium, who wants the next? Right ventricle.
No.
Through the
first,
tricuspid.
We're gonna go through the
tricuspid first.
Tricuspid.
Tricuspid,
Right
right?
ventricle.
It goes into the right ventricle. Where does it go from there?
Through the pulmonic.
Pulmonary, out. I mean, bolt. Pulmonary bolt.
Okay?
Pulmonic valve.
Pulmonic
Into the lungs,
valve,
through the
into
pulmonary artery.
Artery, right? Remember, this artery is not oxygenated, right?
Deoxygenated blood.
Poorly oxygenated.
Deoxygenated.
Right. Poorly oxygenated.
Sure.
Okay, good. So then after that, we go to the pulmonary artery through
To the lungs.
lungs. Yeah, we're just right and left. Okay, so
To get
we're going through
oxygenated.
the lung system, right? We're picking up oxygen and we're coming back through.
Pulmonary vein. Pulmonary vein.
Okay.
Into the left atrium. Atrium.
Left
Left atrium.
Through the mitral valve.
Okay.
Mitral
mitral
Left
valve.
Left
ventricle.
ventricle.
Everybody's talking again. Left ventricle. We're getting excited at the end.
Aortic valve. Through the aorta.
Okay, so if you really keep that in mind,
To the rest of the
right, it's gonna help you a lot with doing murmurs. If you keep the flow where it is, right? So keep it in mind with that. That's how it works, right?
You could say anything.
What's up with this?
That's how everything was sounding.
Oh, when everybody was saying that. Well, great job. Okay, so apex we talked about. Systole is which phase of the?
contraction.
So that tends to, what physical components does that relate to?
Ventricle. Left ventricle.
Ventricles, right? Okay. And diastole?
It's like the filling, or the
So
relaxation.
what relates to what physical?
The ventricle filling.
Okay, from what part?
The
From
atrium.
right atrium.
Okay, so this is keeping this in mind. This is just terminology, right?
Mhm.
Let's say your name. Okay, so key landmarks, this is important here, right? Obviously, your heart is shifted more on the left side a little bit more. You know, the sternal angle, we also call it the sternocleidomanubrial joint, right? This is part of the what?
The sternum.
This part is the manubrium. It's like a hammerhead or something like that, right? So can everybody feel on themselves? Are you trying? You kind of answered before you even tried. You can feel the top notch, can't you, right?
Yeah,
You're right, because you feel like a little bump, like a ridge.
yeah.
So we know if we fall to the left, and what happens? We have a rib there, right?
Mm-hmm.
Yeah.
And then you go one below it.
Yeah.
What space is that?
Number two.
Second.
Seconds,
Second.
that's how you find your seconds. Because it's a little tricky kind of finding if you
On
go
the
from
left,
the
right?
top part on there, right?
Yeah, you gotta go down.
Yeah, so the ribs come in at that joint. Right? So there you go, there's your second left. Alright, so we're gonna do this, right? So now can you walk down one,
Yeah.
feel the rib, and then go to the next one, what's that, third? Keep going.
Ribs.
Keep this decent, keep it decent in class. Can you keep going down one? Who's still following this exercise? Am I the one touching myself here? It's kind of me. Because if that doesn't look right, if I'm the only one up in front of the class that's doing this, because everybody else is doing this, then we got a group thing going on. Or we keep going, right, somewhere, and then we can go okay, clavicle, what's the clavicle?
Right here,
So mid-clavicular would be like,
in the
The
middle.
middle.
kind of obvious, right? I mean, it's, yes, so these are, you know, these are important kind of landmarks, right? You know, this is very
It's hard with
easy,
like a
kind of,
It's-
you
you
know,
gotta go like
determine
right,
very
and
quickly
you gotta go
on
underneath.
people who are skinnier, right? And they are more lean up there, because you can feel that sternum joint go across and right underneath his second. Because otherwise, how do we do cardiac assessment, right? The patient's in the bed, and what do we usually do? What do you do?
Lie them down.
Just kind of guess. Like a dartboard?
I just straight up auscultate.
You just start going at it. You're not sure where you're listening, what so you're not really, maybe you're not particular. You don't go out of your way to hit 2 or 3, you just kind of, what population would you do something different?
I work with kids, so it's whatever I can get.
Whatever you can get, they're pushing and stuff like that, okay. How about people who work with adults? Do you guys actually
It's hard.
palpate
It's sometimes hard, especially like also women
women?
like with breasts and stuff.
Breast
It's hard.
couple issues on there,
You're like,
right? You
"Excuse
go over the
me."
breast or you listen under the breast?
Under.
No, you go
You do the best you
underneath.
can, right? Yeah, you try, yeah, right, that's okay, right, that would be the best thing, and it's still sometimes, despite that, with some women patients, it just doesn't work perfectly. So in that regard, you might, you know, you just do it, or if you write in your assessment, would it be okay to mention that you could not auscultate certain points because of either their tissue or some parts? Yeah, you could do that, right? I mean, that would be reasonable rather than just kind of making it up, so. Okay, so we talked about this with the flow, right? This is kind of gives you just that kind of spatial area, you know, where the tricuspid tends to be a little bit more center to the right. You know, the sternum's not here, right? The aortic is a little higher here. The pulmonic, and then this is the mitral. So this will determine where we kind of listen. And remember, it's not exact on stuff because you do have the sternum blocking some things. Maybe if you didn't have a sternum, you know, you could kind of be more direct over it. So we kind of have to go where it the sound reflects to. So we saw in the last picture the aortic was a little higher. So what position is this?
Second intercostal space to the right of the sternal border.
Right by the sternal border. Okay.
Second.
Pulmonic, second to go to
Pulmonic,
space,
left of the
left,
sternal border.
left center.
Okay, sometimes there's a third point here.
Arabs.
Second pulmonic point, right?
Arabs.
I'm not sure. I'll stop there.
Third.
Okay, so there could be a second pulmonic, right? Where is this?
The tricuspid, the fifth.
Fourth or
Wait,
Fourth,
make a
fourth
little
or,
line fifth.
no, it's fourth or fifth left sternal border.
Okay. This doesn't look quite right, right?
No, fifth is midclavicular line.
See, that's why it was put on there, right? To see if you catch it. Okay, that should be, maybe
That
that's the
one's a
fifth,
little
but it should be right fifth, mid-clavicular, right?
Yeah,
I'm not sure
should
that's
be
actually
lower.
mid-clavicular.
Like
but-
yeah, it's
Can't
right
tell.
there.
fifth,
Right.
yeah. So it's a little-
Look there, it goes.
See,
Okay, so there's
tricuspid
kind
is
of a
fourth.
different drawing on this, right? This particular drawing likes Herb's point very much, bigger diamond in the mitral area. So that's why it's important to feel the structure, right? As best you can, always go for where you're gonna check for first to find the position?
The sternal,
Sternum joint. We're gonna go across, find the
Second,
second rib, fall below it, and your second. And then you just kind of count down, right? Third rib, third space,
yep.
fourth, got it. Yep, I got it.
Amen. ¿Cuántas gordo eso? A ver, ¿dónde tú lo vas a ver?
Okay, so this has to do with kind of pressures of this. We of course know that the greatest pressure occurs during left ventricular
Una
contraction.
vez por ahora, you can.
You know, why is that the greatest pressure?
PMI, I mean left, fifth intercostal.
Okay, so that's where you may feel it. That's where you actually may be able to physically feel. But why is the left ventricle the greatest amount of pressure being generated?
Coming from the rest of the body.
Okay, and it's a larger muscle as well too, right? So it has to circulate all the way even down to your toes.
Yeah,
But the pressure falls over time throughout the body, obviously, right? And that's why if you're diabetic, you don't take care of yourself, usually the parts that go first are
Your feet.
your toes, right? Because the circulation is poor, the pressure is down there.
Can't reach the foot.
So phases of this, we won't go too much into that. Okay, this is kind of the same thing we're talking about. There's other slides that kind of, to suggest on this, so.
This is a cute little picture.
Which slide is cute? This one?
Yeah.
Okay. So we're listening to the heart sounds,
It
right?
looks like
So
you're
S1 course, now we're overlaying heart sounds with the conduction system, right? This would be an EKG, right? ECG, or technically, what lead is this probably? Probably two. Looks like two.
Yeah.
So anyway, S1 is the heart sound, is related to what?
Atrial contraction.
Does that relate to this picture here?
Oh.
What does it sound like? Love dub, love dub, love dub, right?
Yeah.
So this QRS complex is what? Initiating what?
Ventricular contraction.
So S1 is,
ventricular contraction.
okay, so it's systole, right? It's gonna occur systole. So you can tell in your patient, if you're kind of listening, you're confused, you just feel the pulse at the same time, and you'll know S1 from S2. Because love dub, if you say dub, love, right? You can hear that, you know, you can kind of get like disoriented on this. S2 relates to diastole, you got it. And then sometimes there's extra sounds, right? S3 can occur, occurs more closely to S2, while S4 occurs more, so it's not normal to have these sounds necessarily, right?
Right.
So. So this is listening to heart sounds. So S1 we determined is usually it's the sound of what?
Closure of mic.
Oh, this broke out there, right? And tell me why again. How related to the contraction of things.
The ventricle.
So tell me what happens. The ventricle contracts, the blood goes in the left ventricle, right? Goes where?
It goes
Into
out into the
the-
body.
Aortic.
The aortic valve.
Aortic.
Okay, it goes into the aorta through the valve, right? And it forces what valve closed?
The
The
mitral.
mitral, so it
Okay,
doesn't
there you
back
go. So
up.
that's the thinking, right? I mean, even though blood, it stays open during diastole,
Uh-huh.
it closes because of the pressure through that. So it's kind of important. I know I'm kind of repeating this, maybe for some of you it's kind of slow-mo we're doing this. But I think if you really kind of get this, then it becomes just easier to dissect when you actually have to do it.
Uh-huh. No,
That's your uh-huh?
no, I meant it
Oh,
though.
that's what you meant it. Thanks,
Yeah.
thanks for doing that.
No, I'm serious. Like
Okay.
as you're going slowly, like it's just.
Okay, I'm trying to build off
Yeah.
or something, but, okay, Okay, what's S2?
Closure of the aortic wall.
So now
Let's
it's
go back to
start,
S1
it's,
for a second. Well,
fitting.
what else closes on S1?
Tricuspid.
Let's not forget that we don't primarily hear that
they, right.
as well, right? It's not so easy to hear, it's kind of behind the sternum a little bit more, so that's not the primary sound we're gonna hear.
Okay.
So, but remember, you could have a tricuspid problem, and you could hear it on S1. You would expect to hear it on S1, correct?
Yeah.
Right, so a murmur related to the,
Tricuspid and the
You know?
mitral would be S1.
depends, it could be either ones, right? Whether we have a stenosis or
Or
regurgitation. What's the difference between a stenosis and a regurgitation?
Stenosis, it's not,
What's a
it's
stenosis?
not
Narrowing.
opening all the way.
A narrowing, and it creates a,
Stop.
A
give me your
murmur.
best, give me your best murmur sound. Something like that, squish or something like that. There's many different ones, right, depending on the severity. But that's so it's pushing it through a narrow opening, creating a sound. That's the turbulence there. Right, a regurgitation would be
It's not closing
Not
all the way
closing,
back.
it's
below.
backing
back
up, it's
below.
backing up.
So it gives you an idea, right? If it's pushing through, it has to occur on that contraction. She's pretty good, yeah. So, right, they both occur on a contraction, but you got to think about where the direction of it's flowing, right?
Uh-huh.
Stenosis is forward moving, regurgitation is like the
Backwards.
toilet backing up, backward moving.
Yeah. Why does it say rarely detectable?
What do you see?
Under S1, you're talking about the tricuspid, not the mitral, right? The rarely detectable part?
I don't know what that refers to actually.
Okay.
Really?
No, because you were saying that the tricuspid, it's,
Maybe that's.
it's
I
harder
suspect
to.
it relates to the tricuspid.
Okay.
Yeah. So, and either of them can split, right? You know, you can have a split M1, M2. Remember that they tend to be heard as one unit sound, but they can have delays between them slight. It doesn't mean it's always problematic, especially you might hear that on S2 sound. What closes during S2?
The mitral and the tricuspid.
The aortic and the
Aortic
pulmonic.
and pulmonic.
The aortic and the
I know, it's
pulmonic.
easy to get it messed up, right? Isn't it kind of easy to say, like, that's what I said, you really gotta kind of just keep the flow in mind about why. Tell me what the reason is S2. S2 is diastole. So what is
The ventricles are filling.
Feeling.
filling, but that's not so helpful in the perspective of thinking of these sounds. But what's pushing?
The atrial is pushing.
The atrium.
The
atrium
atrium's
is
pushing the
contracting.
blood
Yeah.
It's
into the
flowing
ventricles.
through the mitral or tricuspid and forces the other two,
To
To
close.
close.
right, the other thing snap back.
Okay,
Right, close.
so,
Yes, which is
So
the
the one-
pulmonic and
okay,
the.
so the S1 you're
and the
saying
aorta
to
closing.
view it from the ventricle side, and the S2 is useful to view it from the atrium side.
Right, I think that's it. You're going to really see what's kind of opening, and then therefore the other pair are closed.
Okay, so
On
making
this,
the
right?
noise.
And it can be normal to have a split between the aortic and pulmonic valve closing, you know, because remember the pulmonic valve opens up to what?
The pulmonary arteries.
No.
Right?
The pulmonary
Pulmonic artery
artery.
going through the lungs.
And then
Right, so
coming
that's
out.
kind of the networky, pressury thing. So that can be a little slow,
Mhm.
right? Because there's a little back pressure. So imagine if you're forcing, so there's a much more technical way to do this, but if you're forcing a lot of pressure into kind of a high pressure situation, you tend to have pressure coming back. So the valve can stay open a little longer, and the aortic is less pressure. Correct? Blood moved on, it went forward, it's less pressure moving through. So therefore you can have the aortic closed, then the pulmonic closed. So you might hear like, let me see if I can do my best impression. What might it sound like a split? Does anybody know like a difference between like a difference between maybe like an S3 and a split on an S2?
Is that like hearing both?
So you might hear like a, let's see if I can tap it out. I'm not that rhythmic, so let's try it.
She's trying over here.
That would be a good one, right?
I'm very serious.
What sounds over this?
That's a S3.
That's like a-
All the sounds.
It's
That's the sound.
S1.
Here's the fancy names, whatever they want to call them, a gal,
That's
but
an S3.
all the sounds. S1, S2, S3. Right, so you have to say S1, S2, S3, right? So that's the extra sound, but a split is a little closer. It's more like a split, like a, just a subtle. It's not like a, where there might be a pause. So this is all perceptual, right? You
Yeah.
gotta have kind of good hearing, and it's
It's
all
hard to
very
hear
quick.
that. It's hard
It'll
to
be
pick
like
up on that.
It's never one never ends before the other closes. So that's what a split would sound different. And so, of course, when we're listening to heart sounds, we have to have a really good environment for listening to heart sounds, is that
Yeah.
right?
Quiet.
It can't be too noisy. It seems like you gotta have a good position for people. You gotta be in the right place.
You gotta have a good stethoscope.
You have to have a good stethoscope. Anyone wanna show us a good stethoscope? Anyone have one? Just in case. We're not, again, I told you, we're not using a yellow infectious
I bought
disease
one.
one. What class is that one?
The cardiologist.
Yeah, so at least the cardiology, 3, yeah, at least that would be the one to sort of come in at. If you have less than that, I would upgrade.
If you have what?
Less than a cardiology stethoscope. Because we're responsible to hear these sounds, right? And if we're missing these sounds on our patients, it would be standard of care that we detect these sounds. So that would be, we would be held to that standard. You don't have to go above and beyond it unless you like it. There's ones that kind of amplified, and there's that. Okay? This is like the top view of the heart, right? So you can see the difference just in the size of the valves, right? So when you can hear when obviously you have problems with your mitral valve, right? It's a very, very loud sound because the valve is very, very large. Yeah. I should have brought one of my dogs. She has a terrible mitral valve. And really, you can
Yeah.
You know what, I think it's kinda like the breeding things they got going on, right? They're kind of think the gene pool gets too limited or something like that, even though, you know, they're rescue dogs, but they think the gene pool gets a little narrow, they don't get good like, gene producing into it, right?
Is she a mutt? Or is she like
Well,
a
she's a beagle,
purebred? Oh
you know?
my goodness, I used to have one.
Yeah.
They're wild.
They're wild, what way wild?
Mine was nuts.
Nuts. I have to find they're terrible walkers, cause they sniff too much.
The whole
You
time.
can't like walk and you can't get
The whole
anything, they pick
time.
up eat stuff all the time and.
They're
We
always
talk
hungry.
about electrical versus mechanical activity. So it's possible to have a normal, not for long, I can assure you that. It is possible to have for a little while, normal conduction without mechanical activity. But if you keep
Yeah.
that up, it won't be too long before you have no activity. You know, that's when you're going toward the light.
Always electric activity.
Got it. So, you're pretty much cooked when you got that going on, right?
Yeah.
Okay. So we talk about cardiac output, right? We send our patients for echoes, and we talk about cardiac output, right? This is really what it is. But it's the heart rate times stroke volume, right? Which really means what? What would be a better way to put that? Just more simplistic, right? Over time. It's not really per heartbeat. It's over a certain time, heart rate is over a minute.
Yeah.
So it'll be over a minute, amount of blood that comes out in a minute. That's your cardiac output. So it really has to do with different factors, preload, contractility, afterload. We've heard all this stuff before. So tell me what preload might be.
The amount of blood coming to the.
Money that's in building.
Could be, right? It's an issue that occurs before entering the heart, is preload. So it could be the amount of blood that's returning into the heart. That's a problem, right? Could be some other issue downstream as well too. How about contractility? We'll call it interload or something like that. You know, that has to do with actually in the heart, the ability of the heart to pump effectively. That depends on a lot of different things. You know, of course it depends on how well the conduction system works. What other factors might it depend on? The muscle and the structure of the muscle. People with LVH, right, have a large what? Left ventricle, usually because of,
Cardiomyopathy.
right?
Cardiomyopathy.
Because of cardiomyopathy, could be
Hypertrophy.
genetic, it could be other reasons, it even could be heavy metals. There's some interesting studies, heavy metals kind of deposit in the myocardium in there, right? So it could be that, it could be because of an afterload issue, right? Like hypertension, narrowing of arteries. You know, it could be narrowing, but also stiffening of arteries, right? Do arteries stiffen over time?
Yeah.
They start to, because remember, arteries expand and contract. They're not like a pipe in that regard, so that's where, but they become more like a pipe, right? Or they calcify over time. You know, so that's kind of happening in all of us. There's many different factors that occur, right? It occurs from the actual physical structure change. It can come from the metabolic changes that occur, you know, in the nitric oxide system and what causes vasodilation. Right? So we know there's different hormones that cause contraction, things that cause, you know, we do ACE inhibitors for what reason?
To decrease angiotensin two.
Which does what?
Ventricular,
It's a
decreased
con- it's
ventricular
a-
remodeling.
Yeah, she said that.
What did you say?
To decrease
Ventricular
ventricular
remodeling.
remodeling.
To prevent.
Okay, but why?
Why? So
That's a
Because
downstream effect.
It constricts
So
the
you
blood
don't
vessels.
want-
Constriction,
Yeah.
contraction, so that tells the arteries to contract.
Yeah.
Right, it's not so much of dysfunction in that system, but it's usually dysfunction in the other system, like nitric oxide causes it, like nitrates, we know, you get nitrate,
Dilators.
they get headaches and stuff like this, because they start getting a lot of blood to the brain, right, causes
Relaxation.
relaxation,
Dilation.
expansion of the dilation of it. So it's usually a problem with the nitric oxide production, the metabolic diseases that occur with that. So you know when we say something is like essential hypertension, you ever heard that word?
Yes.
So everything in this world has a cause, right?
Right.
And we cause things like iatrogenic, we don't know the causes, we don't know what they're you know. We call it essential hypertension as though it's some primary cause unto itself, but everything has some cause, It just means we don't exactly know what it is or what level the metabolism breaks down. And like our bodies, like cars, we run less smoothly over time. It's usually going to be a result of oxidative damage that occurs and continues to, to accumulate over time. So oxidative damage changing gene expression as well too, the ability to create metabolic factors or the problem with mitochondria functioning over time. So it occurs with dysfunction on the blood vessel wall occurs with that lever. And we talked about afterload already, maybe like hypertension, right? Something that causes narrowing or some pressure in there.
Mm-hmm.
All those can change the cardiac output. Okay? So I guess they're just telling me what the cardiac, wouldn't even say what it's actually showing here. Let's not pay attention. Okay, factors affecting heart rate, right? So we know that it's where the nervous system and the hormones interact. We already talked about hormones that are involved, or epinephrine, things like that might be that, or we call it adrenaline, or we don't really call it adrenaline, we call it epinephrine.
Mm-hmm.
We know that the autonomic nervous system comes in there. Is that true?
Mm-hmm.
Give me an example of medications that might work on the autonomic nervous system. It is things that change rate.
Epi.
What, sorry?
Amphetamines.
Amphetamines, right? Okay, yeah, they can speed it up on there, right? Beta blockers. So tell me more about that.
Well, it goes the rate,
Beta what?
beta 1, beta 2.
Beta cells.
Okay, it's usually beta 1, right? We're blocking beta 1 receptors,
Beta 2 is 1.
right? Yeah, okay. So beta receptors cause what when an agonist hits a beta receptor, a beta 1 receptor, what happens with the heart?
Slow the heart
In-
rate.
An
No,
agonist
it enhances it.
increases.
It increases.
If it's an antagonist, it decreases.
Beta blocker.
Well, no, we're
No,
talking
he's talking about
agonist, not an
agonist.
antagonist. That would be a more technical term, right? Agonist is it activates it, so it causes the heart to go
Faster.
faster, right? That's where some of those things like amphetamines will operate on those, right? As well, so they're all part of the sympathetic nervous system, which is part of the autonomic nervous system. And then we use beta blockers too. I mean, these are all just kind of little patchwork remedies, right? We're not obviously we know we're not fixing much dysfunction. We're just kind of blockading receptors. And therefore, so when you blockade the beta 1 receptor, what happens?
You're
Slow the heart rate.
decreasing
Slows down
the
the
heart
heart.
rate.
Okay, slows down the heart rate, right? So other things affecting fitness and age, we kind of figured that out, right? That probably has to do with the muscle strength on there, amount of oxidative damage as age has something to do with the accumulation of that, right? How much wear and tear you actually have on your physical body.
Mm-hmm.
And now things that affect stroke volume, right? I mean, actually your physical size, fitness level we talked about, preload, afterload. So, okay, that breaks it down a little bit more.